Hi, everyone. Welcome to another session of Virtual Global Spine Conference. It's my true pleasure to have my friend and new spine and peripheral nerve partner at University of North Carolina in Chapel Hill, Dr. Mark Attiah, here with us tonight. Dr. Attiah did his residency training at UCLA a few years ago, and then he went on to do both dedicated spine and peripheral nerve fellowships at the University of Miami. So, Mark, take it away. Really looking forward to hearing this talk tonight.
All right. Thank you, Mike. Hello, everybody. Thank you for allowing me to be a part of this. I have watched a number of these videos over the years, so it's really an honor that I'm getting to come here and share with you guys things that I think are important. So as Dr. Galgano has mentioned, so I am specialize in both spine and peripheral nerve. I believe that it's a really nice combination of things to focus on because I'm very interested in improving people's function. One of the things that I've noticed since I started seeing patients is that there's always been this kind of, well, it could be a spine issue or it could be a nerve issue. And so speaking with a lot of other people, there's always been this kind of, well, nerve problems are something that are there, but we don't know exactly how to distinguish things in the best way. And so I wanted to share with you some kind of quick principles that I think would be helpful for anyone, really, spine practitioners or anybody when seeing patients to be able to distinguish between spine and nerve problems. I don't have any conflicts. So we'll start off here. At all of my clinic visits, I have patients fill out a pain diagram. And so these are two patients that I've seen. And so you can see across the top, it's color coded. So numbness is yellow, pins and needles are purple, burning pain is red, aching is blue, stabbing is green, and then other, whatever that might be. So, so Dr. Galgano, if you had to guess, there are two patients here. One has a spine problem and one has a nerve problem. If you had to guess which one is which one would you guess and why?
Gosh, I'm not sure, to be honest with you, Mark. If I'm truly guessing, I'll say the person on the left has a nerve problem. The person on the right has a spine problem. But honestly, I really have no way, based on this color diagram, of really deciphering because there's a significant overlap of radiculopathies and peripheral neuropathies. So I
Right,
don't know.
right. And you don't get any history, so I'm cheating a little bit. Um, Same thing here. So there are two patients here. One has a spine problem, one has a nerve problem. Um, and it's not uh, both. Um, if you had to guess, what do you think?
So you say mix of both. Let's see on the right side. What do you mean by that? Or what does the patient mean by that mix of both?
Uh, the patient had a mix of both numbness and
I see.
paresthesia.
I see. So if I had to guess, I'd say maybe the patient on the left has a radiculopathy, the patient on the right has a peripheral nerve issue. And the only
Okay.
reason I say that is that a lot of patients, if they have a distal peripheral neuropathy, it doesn't, at least in my experience, doesn't always travel up the arm. A lot of times it's a little more distally oriented to discomfort. Although I did see someone today that I referred to you that has EMG confirmed ulnar neuropathy, and she actually has parascapular pain as well. So, but you're
Mm-hmm.
the expert, so I'm going to let you explain to us.
Mm-hmm. Good. I will come back to this at the very end. So my goal here is to help everyone's patients get better sooner. I know that we have a lot of doctors here who see some of these patients, and I think when you're seeing these patients, being able to get an accurate diagnosis, or at least have a suspicion of what the diagnosis is, and getting an expedient workup uh, would help them to get to where they need to go faster. Um, so the point of this talk is there are three principles that I'd like everyone to keep in mind. One is time, one is territory, and then one is testing. I'll talk about some techniques that you could use to try and differentiate between the two, and then some scenarios and tips to have in your back pocket. So the commander's intent. So, in the military, the commander of a brigade will have a commander's intent, which is explaining what the goal of the mission is, so that if the group splits off or loses comms, then they can operate independently toward that goal. Let's say, we need to take that bridge, so everything they do will be focused on taking that bridge. So my commander's intent for this particular talk is for you to have some index of suspicion for a peripheral nerve problem, not a high index, just some index. Because when you start thinking about things in terms of, oh, this could be a spine problem or this could be a peripheral nerve problem, you're much more likely to think about how I can get to the right answer. Now, one of the things that I've noticed is that a lot of patients, when they come to me for peripheral nerve problems, that they have seen a number of doctors already. They've seen, I would say, on average, 3 to 6 doctors before they've come to see me, for a number of reasons. People may not know what's going on. They may get the inappropriate imaging, or they may not know who to send these patients to. And so a lot of these patients end up going back and forth. And by the time they get to me, they've unfortunately had a lot of pain, a lot of numbness, weakness. And so I know that this is an ongoing problem. So the problem for, I think, a lot of folks who see patients who have peripheral nerve issues is that, they have, it looks like spine problems. You have numbness, you have tingling. You see a patient who has neck pain, it goes down their arm, it might go into their hand, there's some numbness. They might have some pain-limited weakness, and then you have no imaging. So the question for you is, what do you ask them? What do you do? What do you order, and who do you refer to? So again, I want to kind of hammer home that there are 3 guiding principles that you can use. One is time, one is territory, and one is testing. So for time, I want to reiterate that when thinking about nerve patients, is that as opposed to spine patients, the history and physical is extremely important. When I first got into peripheral nerve surgery, I I mentioned, okay, well, let's get an MRI, and my mentor said, "Are you serious? That's not going to tell us anything." And so I thought about that. There's so many times in spine where they might have radicular symptoms, they might have some myelopathic symptoms. We're going to get an MRI, we're going to take a look at their cervical spine, we'll take a look at their thoracic spine, or we'll take a look at their lumbar spine. A lot of doctors won't even see patients without having an MRI ordered in the first place. That's not so with peripheral nerve. So it's extremely important to get a good history and a good physical. And so things are a little bit backwards when you think about it that way. So imaging is it's almost, it's just an adjunct as opposed to one of the main diagnostic tools. So you've got to think about, what could this be if this is not a spine issue? What could it be? And there are a lot of different neuropathies, the most common of which is diabetes. Diabetes, diabetes. It's the most common peripheral neuropathy. Up to 20% of people with diabetes over time will have diabetic neuropathy. If they're tested by EMG, it may be as high as 50%. There are autoimmune neuropathies. There are chemical neuropathies, the most common of which is chemotherapy for cancer. And then there are medications that can cause neuropathies. The ones that I'm concerned with primarily are structural. And I like to separate them into three groups. You see a pattern here. They all start with T. Tunnels, trauma, and tumors. So tunnels are compressive or entrapment neuropathies, including your median nerve, your ulnar nerve neuropathies, fibular nerve, and your tarsal tunnel neuropathies. Trauma is something that I see quite a bit, either from things like motor vehicle accidents, ballistic injuries, stab wounds, and then iatrogenic injuries, nerves that get either compressed or injured as a result of another procedure. And then tumors, the most common of which are your benign tumors like schwannomas, neurofibromas, and then much more rare is the MPNSTs. So a lot of the symptoms that can happen with these neuropathies kind of mimic myelopathy. You have a patient who comes in and their hands are numb, their feet are numb. I would say half to 75% of my patients say, "Oh, my toes are numb," and those symptoms are similar to a lot of these metabolic neuropathies that I'm listing here: diabetes, alcohol, some other ones, Guillain-Barré. The thing to know about those is that they are length-dependent demyelinating neuropathies, meaning they usually start from distally and then they progress proximally. And so you've heard of the stocking glove distribution of numbness and paresthesias. Structural neuropathies like entrapments, your carpal tunnel, your cubital tunnel, they're usually unilateral, they're usually very focal, and they don't have these upper motor neuron signs like spasticity. So timing is also important for radiculopathies. So we talked about there are some radiculopathies that might mimic peripheral neuropathies. And there's a time-dependent component to this. So usually the most common presenting symptoms for a radiculopathy is pain, right? That's why people they come to you because they're in pain. And then sensory symptoms, so pain and numbness, and then weakness and atrophy come much later. So the nerve root, as you can see here from the diagram, is a combination of the ventral and the dorsal rami, which come together to form the nerve root. So spine nerve roots are mixed nerves, which is important. Peripheral nerves all over your body are either sensory, motor, or they're mixed, which do both. So by definition, these spinal nerves are mixed nerves. But the symptoms of peripheral nerve problems depend on the type of nerve that's being affected. So if you have, say, a lateral femoral cutaneous neuropathy, which is neuralgia paresthetica, which is right in front of your thigh. If you put your hands in your pocket, that's the cutaneous area that nerve supplies. It's a pure sensory nerve. So you're not going to get any motor weakness. Whereas if you have an ulnar neuropathy, which supplies a lot of the sensation in your hand, as well as some of the intrinsic muscles in your hand, you're going to have a combination of the two. So it depends on what nerve it is. When you have spine problems, one thing to note is that the time of day matters. So spine problems can fluctuate over the course of the day because the spine is a weight-bearing structure. Nerves aren't. And so a lot of neuropathies, they may fluctuate, like for instance, carpal tunnel may get worse at night, but that's because a lot of times people sleep like this. There could be fluid that builds up in the wrist. But by and large, over the course of the day, neuropathies tend to remain relatively stable. So you'll see people who say, "Oh, my back problems they actually got better. You know, I did some physical therapy. It's gotten better. Or I'll have this position that works for me. This position doesn't. With nerve pain, it's not so much. The other the most important thing when it comes to time is inciting events when it comes to peripheral nerve issues, um, specifically injuries. When you have a peripheral nerve injury, either in the brachial plexus or somewhere else, a clock starts ticking um, for reinnervation. If it's a motor nerve and a patient gets weak after an injury, there's grades of what that injury is, and how they recover depends partially on how bad the injury is. But a clock starts ticking. So the nerves, when they're damaged, they can either be stunned, which is a neuropraxia, and they can wake back up, or they can be the axons within the structure of the nerve can be partially damaged, or the entire nerve could be separated. So when that happens, the healing process needs to start within a certain time frame, or else the muscle becomes to get chronically denervated and will become atrophic. It won't work. And so that's why it's very critical to identify these nerve injuries as soon as possible. So one of the most common ones that we see for brachial plexus injury is a young person riding a motorcycle, helmeted or unhelmeted. They'll have a motor vehicle accident, and they'll have a stretch injury of the brachial plexus. There was an individual I saw not too long ago who had something like this, and he had an avulsion injury of the upper trunk. And so he was weak in his biceps, he was weak in his deltoid, weak in his supraspinatus muscle, and he wasn't able to lift his arm, abduct his shoulder past about 20 degrees. So I mentioned before that there are iatrogenic injuries from a number of different procedures, which patients will wake up and they'll have either searing pain or they'll have weakness or both. And you can see here on the right, this is a nerve repair procedure that we do when a nerve is injured. We'll find a damaged section of the nerve. We'll find any scar tissue that's around the nerve. We'll need to basically cut out the damaged section of the nerve, which is neuroma, and then we can graft the nerve, repair the nerve using a cable graft, which we can harvest either from the patient or use a synthetic graft. One thing that a lot of people don't think about is that rapid weight loss can also cause peripheral nerve issues. Nerves are surrounded by fat. They're cushioned by fat. And when you have a rapid weight loss, you don't only lose that fat, in your midsection, for instance. You lose it everywhere. And so some people will report having peripheral neuropathy as a result of rapid weight loss. A lot of times the patients who have cancer or who have chemotherapy will lose their fat reserves very quickly, and this will be seen there.
Mark, can I interrupt and ask you a quick question
Sure,
going back to your comment on a neuroma? So I've actually
sure.
taken out some intraspinal neuromas before. Patients have had painful radiculopathies. We scan them, something looks unusual, looks like an intradural lesion. We open up and ends up just being this kind of cluster of nerve rootlets in a ball, essentially. So how do you address a case like that clinically? How do you know whether or not those nerve fibers that are going through the neuroma are actually functional or not?
That's a great question. So, there are different monitoring modalities that you can use. So you can look at the nerve and you can see the neuroma, which is just a tangled mess of nerve tissue and scar tissue as those axons try to grow past the injury site and grow to their target, and they fail. So one of the things that we can use is an advanced monitoring technique, which is called compound nerve action potentials, where you can stimulate the nerve on one side, and then you can record on the other side, and you can see the integrity of that signal across the length of that nerve. It's essentially a nerve conduction study that's done within the body. And then you can see not just, grossly, but you can also see electrically, is this section of nerve functional? And then at that point, once you find the dysfunctional section of nerve, you can cut it. You cut it sharply, and then you graft it. And so that's one of the more advanced ways to kind of address that problem.
And when you're doing that, there's no situation where you would get retrograde activation of more proximal roots, because I know when I take out a fair amount of intradural schwannomas, and we always run into this issue trying to find the nerve root of origin, especially in these schwannomas where there's a ton of cauda equina rootlets that are stuck to the capsule of the tumor, and it's saying, okay, what's kind of, en passage rootlets, what's
Mm-hmm.
actually going into the tumor itself. And
Mm-hmm.
our residents can tell you that when we stimulate even the nerve root of origin, a lot of times the neuromonitor and tech say, oh, yeah, it's stimming at 2, stimming at 3. And then the closer I get to the tumor, the stimulation potential is actually, there's a decrement in them. And my suspicion is that when you're more proximal on the rootlet, you're getting retrograde activation, right?
Mm-hmm.
Am I conceptually thinking about that right? Is that possible in these neuroma cases too? Or is it a more focused test that you're doing?
So it can be. So you do get retrograde activation. And so what you can do is you turn the stimulation down very, very low. And so you try to minimize that. You can't do it completely. And a lot of times during surgery, we'll use monopolar stimulators, and sometimes you'll get that retrograde activation. So sometimes it's a little difficult. To be honest, sometimes it's a little difficult. And so you try your best to, you turn down the amplitude as only as much as possible in order to get that, get the signal from the other end. Yeah. The timing of the referral. So here, like I said before, this is very crucial. So the workup and referral for a peripheral nerve injury needs to be fast for reinnervation procedures to be effective. So there's a critical window of time after a confirmed injury to a peripheral nerve. Typically, we want the effector organ, the muscle, to be reinnervated by a year. Usually around a year is where the end plates, the motor end plates start to fibrose. And so, there's some give and take to that. But a lot of times that's the kind of rule of thumb. So here, this is a depiction of a spinal accessory to suprascapular nerve transfer after brachial plexus injury. This patient is prone, and this is the suprascapular nerve being isolated out of the suprascapular fossa. And this is, using microsurgical techniques to coapt the two nerves together. So this is a critical window of time, and it's important because a lot of times I see patients and I get to them too late. They had their injury, 2-3 years ago, and they're weak. And unfortunately, there isn't a procedure that I can offer them that will help them. So the second T is territory. So, a lot of people here have, learned the brachial plexus 1, 2, 3 times, and then they've forgotten it each time. And it's that thing that it's been there. It's a bundle of nerves, and I know this one kind of crosses over here, and this one goes there. It's not everybody's favorite. But Dan Rue gave a talk here on this channel a couple of years back. Great talk. I highly recommend if you haven't watched it to go watch it. But one of the main points that he made was that the brachial plexus, as we read it in the textbooks, is wrong a lot of the times. There's a high level of variation in brachial plexus anatomy, and with a prefixed brachial plexus or post-fixed brachial plexus, where the C4 nerve root contributes or the T2 nerve root contributes, and a number of other variations there. This is a picture of the world, and the light blue is how we learned it in grade school, and the dark blue is how big these countries actually are in relation to each other. Everything that we've been told is only right to a certain extent. So there are many variations of the brachial plexus, and we have one kind of general representation. The other thing to know is that, we learn about dermatomes with these nice, clean lines with Netter's atlas, but that's not actually true. There's a lot of overlap between dermatomes and skin distributions, and they take over for each other. And I'm sure, Mike, you've seen this when you take a thoracic nerve root. Patients might complain about some numbness for a period of time, and then it might go away, or another neighboring nerve root might take over time. Shane Tubbs did a really nice paper here where there's a mapping of sensory nerve communication between peripheral nerve territories, and this is one of the figures from there, just saying that there's this overlap. And so instead of these nicely manicured lines between dermatomes, it's much more of a gradient. So when you're testing these patients for their sensation, you've got to think about what's going to be in the middle of that boundary and not at the edges of that boundary. And so examine areas in the center that are represented only by that nerve without overlap. And here's kind of a cheat sheet for that. So C5 is the lateral arm, which is right up here. Okay. C6, the thumb pad. C7 is the middle finger pad, and C8 is the pinky finger pad, and T1 is the medial epicondyle. So those are areas that if you were going to pick a spot that is represented purely by that nerve, those are the spots to pick. Similarly, the end nerves for the brachial plexus, the axillary is here in the lateral shoulder. The musculocutaneous is here on the lateral forearm. The median nerve is on the index finger pad. Ulnar nerve is the pinky finger pad, and the radial is the first dorsal web space here. In the lower extremity, you have L1 is the inguinal region. The middle anterior thigh is L2. The femoral condyle is L3. The medium malleolus is L4. The top of the third metatarsal phalangeal joint, right on top of that toe, is L5. S1 is the lateral malleolus, and then S2 is your ischial tuberosity at the top of your thigh. Provocative testing is very, very important in peripheral nerve, trying to look at peripheral nerve issues, because a lot of times it'll tell you exactly where the problem is. There are a number of patients that I see. I combine my spine and peripheral nerve exams. And so when I'm testing for a reflex, an Achilles or a patella reflex or a biceps reflex, I'm also testing for Tinel signs in different tunnels or areas of potential compression. So I'll test for Tinel sign in their carpal tunnel and Guillen's canal, as well as I'll test for it here kind of at the radial tunnel, at the ulnar tunnel here. It's very nice if you just do all of those at the same time. The so I'll test for these common compression points. It's also a good way to kind of localize where some superficial tumors are. So so nerve sheath tumors like schwannomatosis and neurofibromatosis, they'll have a lot of tumors. I see a number of these patients who have very superficial tumors that are easily visible. Some that are not so visible, but they're very, very exquisitely tender when you tap on them. And so sometimes we will actually plan out the incision just based on exactly where the point of maximal pain is, tenderness is preoperatively. And then testing. So if you have a suspicion that something might be a peripheral nerve issue, what do you do? So one of the more common things that you'll do is you'll order an EMG and a nerve conduction study test, and it can be extremely helpful. So it can help differentiate certain things from others. It will help differentiate focal mononeuropathy from a radiculopathy, or a mononeuropathy from a generalized polyneuropathy, as you might be able to see from some of the other metabolic neuropathies that I mentioned before. It can differentiate a neuropathy from a myopathy, and then you can prognosticate for nerve recovery to a certain degree. So sometimes I will actually get an EMG after doing a decompression to see how they're doing electrically as well. The thing about EMG and nerve conduction studies is that they're very operator dependent. So just like a radiologist, needs to interpret an image, a practitioner who performs nerve conduction studies and EMGs needs to interpret what they're seeing. It doesn't localize things exactly. It will help kind of differentiate certain things, but it's not a GPS satellite. And it doesn't catch small fiber neuropathies. And it's also not useful for myelopathy as well. So a lot of people who are profoundly myelopathic will have a normal EMG. The other thing is that there is a time delay. And so it's not an immediate snapshot of an acute injury. So if somebody wakes up from a procedure and then they're acutely weak, you will not be able to see that in the EMG for at least a few weeks. So MRI is important to a certain extent. It's important to rule certain things out. For the spine, it's important to rule out spinal problems, myelopathy, a very clear radiculopathy from herniated disc, or ligamentous hypertrophy, T2 signal hyperintensity. For peripheral nerve injuries and brachial plexus injuries, it's very useful to see pseudomeningoceles, which is what you see here. This is a patient who actually had a motor vehicle accident, woke up, and then woke up weak in his arm. Got an MRI and then saw these. Basically, the nerve root had pulled out from the spine, and was acutely weak. For the nerves, it's important to see masses. So that's definitely something that you'd want to rule out, that there's a mass causing neuropathy. You can see some increased signal on T2 and edema for certain nerve issues. So that's something that you can see, but a lot of times it's non-specific.
Mark, can I ask you a quick question? Can you go
Sure.
back to the previous slide about the avulsion injuries? I've seen several of these in clinic, and I've always felt like there's not a whole lot I can do. Can you help us learn how to differentiate between like a preganglionic and a postganglionic injury, and which one is someone that peripheral nerve surgeon like yourself could actually help reinnervate potentially in the future?
Mm-hmm. Well, we can help reinnervate both. So if somebody has a preganglionic injury or a postganglionic injury, they are different. So this essentially is, preganglionic is basically pulled out straight from the cord. Okay. Um, Now, if somebody has a stretch injury or a complete avulsion injury or something like that, and they're weak, we wait. So one of the debates in this kind of field is that how long do you wait if there is clear avulsion? Because the earlier that you reinnervate these patients, the better that they do. And so I'm an advocate of actually, if you see something like this and you know that they're weak, you can get an early EMG to document that, but there's no reason to wait. If there isn't a clear imaging correlate of an avulsion injury, then you wait. Typically, you wait about 3 months to see if they're going to regain any sort of function. If they regain some function, then you wait until they hit a plateau. And then it's a conversation about, well, how long should we wait before we consider surgery? Because surgery is a lot of the surgery here would be a nerve transfer. And a nerve transfer is essentially robbing Peter to pay Paul. And so you want to make sure that whatever function that they're going to regain is not going to be enough for their quality of life. So for a patient like this is someone that I would consider bringing to surgery a little bit earlier, because clearly has an avulsion injury, and the longer that we wait, the less likely that his function will get better. I hope that was helpful.
Yeah, absolutely.
So high resolution ultrasound is actually extremely helpful in peripheral nerve. It's operator dependent as well. In the right hands, it can provide pretty useful information about the nerve itself in real time. So cross-sectional area, which is important because there are certain nerves that are bigger than others. And if a nerve gets bigger across a certain area of suspected injury, then we start to think about either there's a mass or there's an aroma, and that's injury that's being healed at that point. It can look at the morphology of the nerve itself and the morphology of the fascicles inside the nerve. And so you can see if the nerve is being compressed by something such as scar tissue. You can see the vasculature around the nerve, and then you can see if the nerve is moving or if it's not gliding as it should. One big thing that ultrasound is useful for is visualizing peripheral nerves in the pediatric population. So MRIs, as a lot of times you'll have to sedate children in order to get them to stay still for the MRI, but you don't have to do that in an ultrasound. So it's actually very useful for this population. Injections, just like in spine, are very useful for peripheral nerve. A lot of times you can have an ultrasound guided injection at the same time as the diagnostic ultrasound. So it can be both therapeutic and diagnostic. So a lot of times you'll get an ultrasound of the median nerve in the carpal tunnel. You can also get an ultrasound guided injection to help with pain. This is also very important diagnostically for thoracic outlet syndrome, which is a collection of conditions that are very hard to diagnose. It's essentially compression of the entire brachial plexus, which can happen as a result of hypertrophied muscles, the scalene muscles, or scar tissue, or bands, an extra rib at C7. A number of things can cause neurogenic thoracic outlet syndrome. There's also vascular thoracic outlet syndrome. It's very hard to diagnose because there is no real good gold standard diagnostic test. If they don't have an extra rib, or if they don't have a band that you can see on MRI, EMGs can be typically normal. One of the things that we can do is an intrascaling block to see if the patient gets better. An intrascaling block can prognosticate a good surgical outcome. So it's very helpful in this patient population. So here's some more common scenarios that you've already experienced, and some tips for those. If you have an L5 and you're trying to determine whether or not it's an L5 radiculopathy or a peroneal nerve neuropathy, an L5 radiculopathy usually starts with some back pain, back or hip pain, and then it radiates down from there. Both eversion and inversion are impaired, and with peroneal neuropathy usually starts from the knee, and eversion is impaired, but the inversion is intact. A C5 radiculopathy should include a number of different muscles. One is the deltoid, the biceps, and even some pectoralis muscle. The suprascapular nerve can look a lot like that from a pain standpoint, but it's very rare, and it only affects the supra and infraspinatus muscles. A C6-7 radiculopathy, again, should affect the biceps, the brachioradialis, wrist extensors, and the triceps, and you'll have a loss of triceps reflex. Carpal tunnel, it's very rare that you'll have motor symptoms, but if you do, it's only the thenar muscles in the first and second lumbricals, okay? And you should test thumb abduction. A T1 radiculopathy goes down your arm, but it usually stops at your wrist, and you'll have thumb abduction weakness, which is the median nerve, okay? With an ulnar neuropathy, you'll have thumb adduction weakness. So to bring it back to the beginning, Mike, you were right. So this patient has a peripheral nerve issue. So this is the patient's MRI of the cervical spine. There's no compression. You have to believe me when there's no foraminal stenosis at any of these levels. The patient ended up having a thoracic outlet syndrome. A very, very clear, not very clear case, but as clear as you can get it, thoracic outlet syndrome. Responded very well to the intrascaling block.
And then what happens after that then?
Sure.
Now, like, how long does that interscaling block last? At some point, are you taking them for an operation, or are they just getting repetitive blocks? How does that work?
Sure. So when you have an intrascaling block, you can have a diagnostic block, which is usually with Marcaine, which usually lasts only as long as that block. At that point, then you have a discussion with the patient. You can have Botox injections in the scalene, which are supposed to quiet down any spasm that's causing compression of the brachial plexus, which again is a Band-Aid. The more definitive thing is a decompression of the brachial plexus, which can involve a number of different things, which is an anterior and a middle scalenectomy, which is the muscles that kind of sandwich the brachial plexus in the supraclavicular fossa, with or without a first rib resection. And then you can also do a decompression or a pectoralis minor muscle release as well. You can have a diagnostic injection of the scalene and then of the pec minor to see which one they respond to. And then you can tailor your treatment based on that. So for this patient, they responded much better to the scalene block than the pectoralis minor. And so the ongoing conversation is surgery or continue with injections. You were also right here, Mike. So this patient has a radiculopathy. So patient has a disc here that's pushing on C5-6. Patient has a pretty significant unilateral arm pain, and here at the thumb, the first two fingers here, but they're very similar. This patient again has a radiculopathy here on the left side. He came in, kind of gripping his arm, saying like, I can't really deal with this. So he got an MRI and he has this. This patient has a musculocutaneous neuropathy, which results in weakness of the biceps and then numbness and pain in the lateral antebrachial area here, which looks a lot like a C6 radiculopathy. But if I had given you the entire story, then you would have gotten in a heartbeat. So that's it for me. I thank you guys for staying with me and listening to some of the things that I find interesting and near and dear to my heart. Thank you, Mike, for having me on, and I'm open to any questions that you might have.
Mark, thanks. That was an awesome talk. We speak every day about all sorts of spine innovation and robotics and navigation and complex deformities. It's really nice and refreshing to come down, and hear a talk like this, because what it all boils down to in clinic is that we're taking the best care of our patients, right? And
Right.
We have to boil it down to peripheral exam 101, which is exactly what this is. But honestly, a lot of us forget this. I mean, we think of this as really, basic, right? I can't tell all of you how much more I've paid attention to peripheral nerve issues since Dr. Attiah started with us at UNC about 5 or 6 months ago. There were so many patients that would come in with what seems like a radiculopathy. We have a scan, it's unimpressive, and we just say, you have a pain syndrome. There's nothing organic on the MRI scan or the CAT scan, and I'm sorry, and we send them the pain management, but I've definitely read up on my peripheral nerve exams. Now that Mark's here saying, you know what, maybe there's a peripheral nerve issue. And, between myself and one of our other spine partners, we've actually been able to find some of these patients that Mark's been able to help, which has been fantastic. So one of the questions I have for you is, how do we bring more awareness to this? Peripheral nerve surgery doesn't get the same type of press, even at national meetings that spine surgery does. I mean, we talk about the spine section, right? It's really the spine and peripheral nerve section, double ANS, CNS. So how do we bring more awareness to get spine surgeons thinking more about this?
Yeah, I think it has to. I think it's a number of things. Because most people in neurosurgery don't go into neurosurgery to operate on people's arms and legs. They want to open skulls, see brains, spine, and so I think it's foreign. It's foreign to a lot of people in our field I think it comes down to the top and the bottom. The people that matter the most are the patients, and then the people who are seeing these patients, and then they don't know where to go or where to send them, and so the patients end up in this cycle. And so I think the way to kind of bring more attention to it is to bring more attention to some of these patients and what they're going through. Like some of these patients are, they're heartbroken when I tell them, hey, if you had gotten to me like 6 months ago, I might have been able to do something for your arm. Or they're in excruciating pain because they have a neuroma, and nobody knows what to do with it, and I can't pick up my baby, please help me. And so I think a lot of these stories, it may not be, the latest robot, but a lot of these stories are very, very poignant. And I think bringing attention to the stories of the people who have these issues, from that mother to folks in the military who have amputation neuroma, and they're in excruciating phantom limb pain. Um, I think bringing attention to those stories is probably, in my mind, the most important thing.
It looks like Dr. Reddy, who's one of our audience members, had asked, let's see, he says, Dr. Attiah, relating to the peripheral nerves, how does one treat nerve entrapment, numbness, and pain, for example, like common peroneal fibular nerve? So I think what he's getting at is just how would you do an operation if you suspect that someone has peroneal neuropathy or entrapment? Maybe how do you differentiate between a simple decompressive surgery versus like a transposition?
Yeah. So if someone comes in with, like, we'll say peroneal nerve, it's one of the most common uh procedures that I do, actually. And so they'll come in, they'll say that I have pain, and it's right here, and it goes down my leg, it goes down to my ankle, and it starts right at the side of the knee, and then I'll tap it, and like, oh yeah, that's really painful, please stop. And so at that point, I'll want to get some sort of imaging, either an ultrasound or something else, just to make sure that there isn't something else going on. One of the variants of that is to have an intraneural ganglion cyst. You can actually have fluid inside the nerve that's pushing on the fascicles of the nerve, which can cause some problems. But if they have electrodiagnostic, evidence, and they have clinical evidence, they have imaging evidence, and they diagnosed with, common peroneal nerve, entrapment at the knee. It's a matter of releasing whatever is going through that tunnel. Usually, it's some sort of combination of fascial bands. It could be scar tissue from a previous surgery. For the peroneal nerve, there are 3 points of entrapment. One is the posterior crural septum, one is the anterior crural septum, and one is the innominate septum. All of these are fascial bands, leading edges of different muscles on the side of your leg. You release all of those, you release underneath the nerve. You make sure that the nerve is basically floating in the breeze before you close. And that's generally it. It's the same thing with carpal tunnel. It's the same thing with cubital tunnel. You open up, you find the nerve, and you make sure that it's released across all the points of potential entrapment along that area.
I've got a couple in the last 2 or 3 minutes. I've got a couple more questions for you myself. Something I struggle with sometimes is when you have these patients that have double crush syndrome. So what's kind of your treatment approach to patient maybe that has, a pretty severe median neuropathy, but maybe you scan their neck and they also have a pretty big disc at C5-6 or C6-7, and they have some overlapping symptoms. How do you approach that? Are you addressing their radiculopathy first, their peripheral nerve issue?
Yeah. So a lot of times, what I'll do is I'll try and address what's bothering them the most first. Obviously, if somebody has a myelopathy, I'll want to address that first. I think Dan Rue made the comments. He sends the patient to the hand surgeon first, so that the second operation is the one that gets all the thanks. If I see the patient and I can take care of both of them, I'll take care of what I think is bothering them the most. If they have a lot of neck pain and this is bothering them more, then I'll take care of this first. There are certain situations where I have done both an ulnar and a median nerve at the same time. It depends on the patient, but it really, to me, it's about what's bothering them the most.
All right, I've got a spine slash peripheral nerve question now. So I do a fair amount of deformity surgery, and maybe once or twice a year we'll do a correction for a patient that has lumbar scoliosis, and there's absolutely no neuromonitoring changes. We get a very reasonable correction. Patient does well for a day or two, and then they may notice that they have a painless neuropathy, or what we would call a neuropraxia, right? I had a patient last year that was an adult that had a really big lumbar curve. It was an adult idiopathic curve, and we had a great correction on her. And on post-op day 2, she developed a foot drop. Her signals were completely fine during the operation. So anyways, my question to you is how do you manage a patient like that who maybe has a painless neuropraxia after surgery, and what's really the pathophysiology behind that? I know that has something to do with some type of a stretch injury, but how do you manage it? How do you counsel a patient in that situation? Because they always ask, okay, when is my foot drop going to get better, or when is my wrist drop, or what have you? So how would you counsel a patient like that?
Yeah. Yeah. So it's tough. So I think, so it's, similar to, your C5 palsies after your cervical decompressions. So it's not entirely understood. Our kind of current thinking about that is that it is a stretch injury. Essentially, you have this stretch injury as your nerve roots are kind of adjusting to their new position after deformity correction or after a decompression. It's stretching, and so over the course of however long it takes, a day or two, then they become weak. At that point, I would start treating it essentially like a stretch injury anywhere else. And that's why it's important, as I've told, the folks here, let me know. There are certain strategies that are useful. There are more strategies that are useful for upper extremity situations like that. For lower extremity, there aren't as many, but it may not be a reinnervation procedure, but it may be a tendon transfer, and those are still patients that need to be seen by kind of the same group of people to determine what the best way to treat them is, even if it's not a reinnervation procedure. Maybe if their foot drop doesn't get better over time, if there's anywhere along if it's the fibular nerve, if there's anything that needs to be decompressed, if there's anything else like that could be helpful, then we can do that. If there's a tendon transfer that'd be helpful for them, if there's a neurectomy that could be helpful for them, we can do that. For the upper extremity, for C5 palsies, there are some strategies that we can use for reinnervating the shoulder. One of them is the procedure that I showed you a little bit earlier, that the spinal accessory to suprascapular nerve transfer, that's part of it. And so I would say it depends on what the weakness is and the timeline. But I would treat them just like I'd treat anybody else who has a stretch injury from anything else.
Awesome. Mark, we got one last question I've been itching to ask you. It's really more along the lines of what's on the horizon for peripheral nerve surgery, and maybe looking beyond the scope of what we see in our clinic. So, I've read some literature on patients that have hemiparesis from TBIs or strokes, or patients with spinal cord injuries what's on the horizon that a peripheral nerve surgeon like yourself can offer someone? Like, is there any role for intradural anastomosis in patients that have hemiparesis after a stroke or a hemicord injury or something like that?
Sure. Yeah. So that's actually something that we are working on here. There are a handful of centers in the country that are performing nerve transfers for spinal cord injury patients. The reason why that's exciting is that the timeline doesn't exist anymore. So there are people who have spinal cord injuries in the distant past. And so that 12-month timeline that I was talking about before doesn't exist because the nerves are still connected to the motor end plate. The problem is in the upper motor neurons of the spinal cord. And so technically they're still connected. And um, so we are in the process of starting to put together a program to identify some patients that could be benefited by nerve transfers. Not all of them will, but certain ones could be potentially helped by nerve transfer even after a spinal cord injury in the distant past. It's something that could be helpful for not only people who have, for instance, motor vehicle accidents, but also people who have military injuries and things like that. Um, there is a growing group of people in biomedical engineering and rehabilitation who are interested in developing bioprostheses for people who have amputations. There's a technique called targeted muscle reinnervation. Greg Demanian over at Northwestern has championed this, which essentially we can take a nerve and innervate a piece of a muscle. If you can take an electrode and put that into that new muscle that's been reinnervated, you can power essentially a bionic arm. So if I took my median nerve and my musculocutaneous nerve and I innervated different parts of my pectoralis muscle, and I plug in, oh, this is the median nerve input to this arm, I could essentially, just by thinking, oh, let me move my arm, I will move the bionic arm in that way. Does that make sense? So it's a strategy we've talked about in other fields of neurosurgery, brain computer interface. This is kind of a peripheral nerve computer interface that a lot of people are kind of excited to try and make a reality. So those are some of the more exciting things in peripheral nerve surgery that are coming up on the horizon.
Mark, that was absolutely fantastic. I personally really enjoyed that a lot. I think the audience absolutely loved it. So that's all the time that we have for tonight. And if you all check Twitter and LinkedIn throughout the course of the week, I'm sure Amna will be posting who our next guest speaker is. So thanks again, Mark. That was fantastic. And I'll see you tomorrow at work.
Thank you. Thanks, Mike. Thank you guys for having me on. Really appreciate it.